Hi there, I'm Kirsty Clegg. I work for Public Health England. So it's just to let you know we are in the room. I work in the Greater Manchester Centre under Martin Regan's directorship. And I think we're just really looking at how we can help enable the research and development system in Greater Manchester. There's certainly a lot of synergies in what I've seen this afternoon, especially around mental health, dementia, comorbidities, long-term conditions, cancer. So I think, yes, watch this space. Thank you.
Okay, great. Thank you, Kirsty. Hi.
Hi, I'm Andy Mee. I'm at the Manchester Mental Health Trust. Picking up on a couple of points made by Angie and Sarah and addressing this as a national question, when are the CRNs going to recognise complexity in studies? Because at the minute the focus is purely on numbers, and obviously within mental health we have highly complex studies. Sarah mentioned the children's complex studies. So when is there going to be some kind of metric brought in on complexity, an acknowledgement of that?
Hi, Andy. I mean, I think what we've just got to do is look at our studies, look at what we need to do to recruit to time and to target, and I think, you know, I think we just have to maximise our opportunities, and we're never going to get in mental health, in Dendron, you know, studies with thousands and thousands of patients. But what we want to do is have a balanced portfolio, and we want to deliver on what we have. And I think there has been discussion around complexity and a weighting system being brought in, but I'm not sure, I don't know if there's been further discussions around that. But I just feel that we have our performance now in 13-14. Let's look at how we can improve it, and let's look at see how we can deliver, you know, a sort of a range of studies across Manchester, and let's work collaboratively together to do that. I mean, I don't get so hung up on necessarily being 9th out of 15. What I feel is we have great team out there in Manchester, and we've got fantastic patients, and it's our duty just to deliver the studies to them. So but I know that we can move. But I think it's. I feel we've just got to deliver what we've got.
So yeah, can I just respectfully challenge the assertion that we don't recognise complexity? We absolutely do recognise complexity in terms of the funding. The funding model that allocates from the DH allocation to the networks.
Steve, often when we don't like what someone's saying,
you just guy. Well, that's just as ineffective. So anyway, it's fine. The funding. Yeah, I was waiting for that. Yeah. So the funding. I'll shout. The funding model does recognise complexity. I think what you're referring to is this. Quotes obsession with so here's the thing, the league tables are a means to an end, and the end is to encourage us all to greater efforts. They're not actually an end in themselves, but from the patient's perspective, what matters is if you pull up in the clinic, are you going to get offered a research study? So actually those numbers of patients recruited, they do have some meaning. But we would agree with you if you were to tell us that they're not the whole picture, and of course they're not the whole picture. There are other numbers that we use to reflect that.
I'm going to add my 2 pennyworth as well, if that's okay. You might have noticed, those of you that don't know, my pastime is also looking after diabetes research, and you might have noticed that doesn't look so good on the charts. But if you actually look at the complexity of the studies, and the numbers that we're recruiting to those, we actually, in commercial and life science studies, we actually do pretty well. So I have some sympathy for the question, but when we're actually sitting at the executive groups and we're thinking about how we parcel up the funding for the different groups and the divisions, we do take it into account. So although those figures are a very stark reminder of just the bean counting aspect, underneath that, we actually do a lot of work to make sure the resource goes where it's supposed to go. So you can be reassured of that. And if the group is large enough and has a balanced portfolio, which most of them actually do, it does even itself out. So if you look at Division 2 as a whole, for example, diabetes sort of evens itself out. And the same would be true in your Division 2, Andy.
Any other questions? Now as we've got the microphones back on. Hi.
I'm Philip Lewis, I'm a cardiologist at Stockport. I perceive there are some major problems, especially in secondary care, where, apart from Salford, where you have the most amazing database, a lot of secondary care has got insufficient databases, so huge amounts of tedious time is spent groping around, trying to find patients for studies, when if the database were there, they would be available. And I think that has to be addressed. Second thing is that long-term studies are recognised at recruitment, but not at continuation. So if you do some of the major long-term international studies for 5 years, you do wonderfully in the first year, and then you've got 100, 200 patients your team are committed to for another 5 years, and there's 0 brownie points for that. And the third thing is the pressure in the trusts between pushing bodies through clinics or through wards and having time to reflect and recruit. And those are difficult things unless to some extent the lead people in trusts, especially at executive level and middle management level, also realise that these things have got to be encouraged rather than get on and get them out.
Can I come in on the last point in a second? But Mark, do you want to start us off with the growth?
I'll do the first two, you can do the last one.
Yes.
How about that? The first point, I'd agree with you, there's a lot of groping going on. And we need to improve our ability to find patients. One of the great things is you hear a lot about the informatics systems in Manchester and how wonderful they are, but as you rightly point out, they're quite patchy. But we're working with our colleagues in the Academic Health Science Network, and Gary Leeming, the lead for informatics for that network, is in the audience today. And we're working with Academic Health Science Centre colleagues in the FAR Institute to make sure that we do have better systems in place to do that. It's not an overnight fix. I mean, I think that, everybody wants to work towards integrated healthcare electronic systems. And there's been a little bit of a fly in the ointment recently, I understand, but it is going to get better. So that's the first one. The second one is around follow-up. And again, it's a little bit like answering Andy's question before. We do know which those big studies are. And although, in terms of the income, if you like, we get is based on the initial recruitment, we do take into account the fact that there are studies out there with long-term follow-up, which is why we try and encourage to have a standing workforce that knows where it is and what it's doing. And that's been one of the great strengths of the research network.
If I can just come in on the latter point about how we build executive engagement around research. As you all know in your organisations, there isn't one team in this audience that isn't, under real pressure in service terms. So it's a genuinely difficult area, but it's one of the items that we've talked through with the partnership group. How we can start to, I think, more effectively start to articulate the benefits to all our patients of being involved in research. Because, and I do take the point from Andy earlier, it's not the league tables in themselves. They just give us a proxy for the fact that we think our patients get a better deal if we're actively engaged in research. The communities we serve get a better deal. And I think that's part of the big challenge that we face as a network, how we can build that level of engagement. So it's not research isn't something separate that goes on over here that doesn't relate directly back to our patients. It's something that has a significant positive impact on the quality of the care that we provide. And it was interesting when you spoke earlier, Steve, saying we look at the CQC and we look at all the different measures. Research doesn't have the degree of prominence that I think, for example, it should do in terms of CQC assessments. But it is one of the issues as a partnership group that we've said we're actively engaged in. Steve?
And one little addendum to that, because you're quite right, often it's the hard-pressed middle managers that feel the tension between if you like, the executive ambition and the challenge of service delivery. This doesn't solve it completely, but what we have worked hard on in Leeds is providing the middle management team with an easy-to-access information system on what research is happening in their directorate or clinical service unit, who's doing it, and how those studies are going. So at least they know where the resource is, because they get an explicit budget statement. So in other words, there's a management toolkit that at least enables them to participate in supporting those studies and to know what's happening, because some of their concern is that research, might be used as a cover for unproductive activity. Rarely is it the case, I think, when you say this is high-end research, we need to do it, they'll generally say, actually, how can we support?
Any other questions? Hi.
Can I just ask a question about how you plan to manage the centralisation of services? I work with Professor Tyrrell out at Salford, and for quite some time stroke patients have come to Salford and then been recruited into trials and then are subsequently repatriated to other centres. And I know that there's a lot more centralisation of services such as cardiac and things like that. When expressions of interest come through to a site, the central site, and you know that you can recruit to those patients, how can you ensure that the patients can continue in the trial once they're repatriated?
Well, I'd like to take that one. To me, it's all about teamwork and collaboration. And the research delivery manager, for example, for Division 2, will know exactly what support she has in each of those trusts and how those patients can actually be followed up. It's really important that once we've got them into a clinical trial, we don't lose them. And we are looking at also having a more flexible workforce. And hopefully, if necessary, the staff can actually follow the patients. But we need to enable them to do that. Yeah.
I wondered whether your question was slightly related to governance around that as well.
Yeah, but there is that aspect of it as well. We've had that situation where there's certain sites we've not been able to recruit if we know they're going to be, repatriated to a specific hospital.
That is a slightly thornier issue, but it's one of the things that we'll be raising with our colleagues in the Academic Health Science Centre and network about how we smooth out and streamline those services around R&D across the city so that we get that. It's a little bit out of our remit, but our RM&G team are working with local R&D groups to try and sort that out. And so Andrew, who's not very far away from you, will be able to give you a bit more about that.
Can I just follow up and just say, I think the new structures will allow a lot more sensible working and the teamwork and collaboration that Debbie spoke about. The previous network structures, we did talk a lot together in the Northwest, but actually there wasn't often a pressure for us to necessarily work together because we were funded separately. And the new structures means that we work collaboratively. So if you take, for example, diabetes and primary care, there are studies that Sue and I potentially will be working very closely on, and potentially go dedicating resource or working in a way that actually doesn't benefit my division, it benefits Division 2. But it doesn't really matter because it benefits Greater Manchester, and it's all about getting Greater Manchester to do well. That's what keeps the resource here. It balances it out. There are going to be areas of the portfolio that have small, intensive, difficult to recruit to studies. And then there are other areas of the portfolio that have lots of large studies that bring the numbers in. It's about balance. And I think the new structures and the new ways of working will greatly enhance how we're able to do that and make it better, easier for us to work more sensibly with the trusts as well. So hopefully we won't be tripping over ourselves like perhaps we might have been a little bit in the past. We'll be able to work with you much more cohesively.
That's quite reassuring because we've also experienced where certain centres within, how it used to work, would recruit particularly well to certain kinds of studies and not to others, and we knew which studies to send where kind of thing, so that's quite reassuring that you're going to work together.
Okay, look, we've got about half an hour left this afternoon, so we will take a break now so colleagues can just talk these issues through informally. Just before we break though, really on behalf of the entire team, can I just say thank you to everyone, particularly for your forbearance during the transition, because I know these changes can often be really quite stressful, but hopefully we're getting to the end of this part of the exercise. So thank you for sticking with this over the past 12 months or so. Thank you as well for keeping such, I think, incredibly high levels of commitment and performance, because as you can see from all the slides today, our network's in a really, really strong position. And again, it's not just the league tables, it's what that means in terms of the impact on individual patients and the communities that we're responsible for. So thank you everyone for all you've put in. And can you just join me in thanking all our presenters for their wonderful presentations?